Hi students, I'm going to start off the semester by doing a little review for ICD-10 CM and PCS. One thing to remember is that here are the official guidelines. And if you look here, it's 115 pages, so a lot to go through. But I'm going to try to highlight. I will give you this link so you can read through, review the different guidelines that we learned last year. So a couple of different things. Make sure you take the time. Use your ICD-10 CM PS handbook. That is a wonderful, wonderful resource. So let's go here. Remember the CMS and the NCHS are the two departments of the government. DHHS, they are the ones who provide the following guidelines for coding and reporting for ICD-10. So with that, these are published by the WHO. So let's go ahead and get down to a few things that you really need to make note of and remember. So we have conventions, so if I click onto this, it'll take me right to convention. So really do like this, and like I said, I will have the link for this. Okay, a couple of different things. Your alpha index tabular. Remember, you always look it up in the alpha, double check it in the tabular, because you never ever know when you're going to miss that fourth, fifth, sixth, seventh character. Format and structure. Characters for categories, subcategories may either be a letter or a number. All categories are 3 characters, so keep that in mind. So then once you get that category, then you want to go to the subcategory, just 4 or 5 digits. So codes, once again, can be 3, 4, 5, 6, or 7. But if it is, you always make sure that you go to the furthest extent of that code possible. Okay, so placeholders, make sure you review that X for that placeholder. And once again, this X could be to hold that place for future reference. So, a good example would be COVID-19. They come up with a different strain, and right now they could be putting an X. So next year they could take that X and use it as a number and come up with a different strain for that COVID code. So 7 characters, a lot of times a placeholder must be filled in to get to that 7th character if you have a 7th character. Okay, review your abbreviations. NEC, NOS, punctuation. Remember, if they're in parentheses, these can be your non-essential modifiers, acute and chronic. Review and then other and unspecified. Include notes, inclusion terms, exclude notes. Okay, I'm just going to go here, exclude 1. This is something that's very, very important. A type 1, it means it's not coded here. So excludes 1 versus this could be, let's say we have 2 conditions cannot occur together. So if we have a situation where a congenital diagnosis being coded, you cannot also code an acquired condition of that same. So if we have a hydrocephalus, which is congenital, you cannot also code acquired. So that's what excludes 1 means. That code cannot be also coded at the same time. Where excludes 2, an excludes 2 note indicates that the condition excluded is not part of the condition. So a good example of this would be if somebody has ADHD, and let's say they also have anxiety. So they could put an excludes 2 note saying anxiety is not part of ADHD. So you need to code it also if they have both conditions, but only if they have both conditions. Make sure you review when you need to code first. And then review your words and with see also, code also, default. Okay, how do we locate that code in ICD-10? So to select that code, you want to go to the alpha. Again, you look for those main terms. And that alpha, keep in mind, does not always give you that full code. So you need to go to the tabular list and look to see if there's more digits or characters. And again, go to the highest level of detail encoding. Signs and symptoms are acceptable for reporting purposes when related to that definite diagnosis has not been established. So when you have a condition that's an integral part of the disease process, you do not code it. So this could be if somebody comes in for chest pain and they diagnose them with a myocardial infarction. That chest pain should not be coded because it is integral to the myocardial infarction. Same thing, a patient comes in with abdominal pain, okay, and they diagnose them with an appendicitis. You cannot code the abdominal pain. You can only code the appendicitis. Okay, multiple coding for a single condition. A lot of times you'll see use additional code. That's telling you need another code. Okay, so again, I'm just touching base on some of these. Acute and chronic conditions. If the same condition is described as both acute and chronic, and their sub-entries exist in the alpha, but they're at the same indentation level, you sequence the acute first and then the chronic second. Okay? So if acute is in non-essential modifiers behind the first word, then you only code the acute. But if it's acute and chronic at the same indentation level, you can code them both. Okay, so make sure you go to your textbook and review this. So let's go laterality. It should state if it's right or left. So here, when laterality is not documented by the patient's provider, code assignment for the affected side may be based on medical documentation. But if there's conflicting medical record documentation, at that point, you need to go with unspecified. You should try not to use, you may have to do a physician query, which we're going to learn about too as we go along in this semester. Okay, so again, just kind of read through these. Signs and symptoms, once again, unspecified codes, they have been accessible, even necessary. So we'll talk about that, the difference between inpatient and outpatient. Okay, so we have sequencing, Z codes. Everybody remembers Z codes. You really need to go for the chapter on when that Z code can be first listed, secondary. Okay, so I'm not going to go into the chapter specific codes, but I do want to touch base on inpatient and outpatient for signs and symptoms. So here's a note, and you can go back to your textbook to review this. But if a patient is inpatient, which means they're admitted, and the diagnosis says rule out, possible, suspected, that means if it's suspected appendicitis or rule out appendicitis, you code it as if they have it. Now, in the scenario where it is outpatient and it says suspected appendicitis or rule out appendicitis or possible appendicitis, remember this is outpatient, you want to code the symptom that they came in with. Here's a little reasoning behind that. The reason you can code it for inpatient is because after that documentation comes to the coder, that means they have done tests. And if it says possible appendicitis, well, that's what they think it is. They've done tests, they're an inpatient, we can code it as if. Okay? We're outpatient, if it says possible appendicitis, they haven't done the test. So you cannot assume that's what they have. You have to code with the symptom. Okay, remember you need to go back and check your rules inpatient. It says possible appendicitis. Of course you can, but there is some diagnosis that you can't assume. One of them is HIV. Even though it's inpatient, it says possible HIV, you cannot code it. Inpatient, possible epilepsy, you cannot code it. So make sure, once again, you review your textbook for these. Hopefully this helps you with a little bit of review. Remember to start off with your main term, look it up, go to the most specific subterm you can, if able, and then double check it in the tabular. All right, hopefully this helps, and this gets you a good start to the semester.